In this section, I will discuss a case which we have done in an elderly male with a renal failure. It's a percutaneous intervention with zero or ultra low volume contrast. To introduce the case, this patient is 74-year-old male, came with class 3 angina, almost crippling angina, because of which he is not able to do his regular activities. And he was in normal sinus rhythm with good LVRV function. His eGFR was 30 ml and coronary angiogram showed two-vessel disease with a anomalous LCX origin. This is coronary angiogram. You can see this is an LAD, so which showed a significant lesion in the proximal LAD, and there is no LCX coming here, so which was actually coming from right sinus. So proximal LAD, significant disease, and this is an RCA, so which is showing significant disease osteoproximally as well as diffuse disease. And we can see LCX is coming anomalously from right sinus and filling while injecting into RCA. So the anatomy is pretty simple, it's not complicated for angioplasty. But in this patient with the eGFR of 30 ml, so how to reduce contrast load by using intravascular ultrasound? So for that we have to go back and understand, why we are giving injections during angioplasty. So if you understand what is the role of first or pre-PCI contrast injection, that is the first injection which you do while doing PCI. So it's basically location of the lesion, severity of the lesion, and anatomy of the vessel leading to lesion, distal and proximal landing zones, identification, and pre-dilatation balloon selection, and probable diameter and length of the stent to be used, as well as distal runoff. So these are the issues which I want to know with my angiography. So now I'll try to explain, can I replace my first injections with intravascular ultrasound? Location of the lesion, obviously we can replace. So we can mark location of the lesion with intravascular ultrasound and fluoro, which we can use for stenting purpose. And if there is a co-registration of IVUS, that helps you more. So, and severity of the lesion, yes, we can replace IVUS, but not completely. But most of the patients, you already have an angiography to decide upon whether patient needs angioplasty or not. So that's why this question won't come when you do PCI. But if this question exists, you can use IVUS, and if the area is less than 2.2 mm square, so mostly it goes with severity. And anatomy of the vessel leading to lesion, yes, we can study this lesion, block distribution in the vessel, and distal and proximal landing zone, of course, yes, we can decide with IVUS more accurately than angiography. And pre-dilatation balloon selection, yes, we can do with IVUS. Probable dia and length of the stent, we can decide with IVUS. Distal runoff, this is the only thing which we can't assess with IVUS. Otherwise, all your rest of the parameters can be done by IVUS, and few of the parameters IVUS is more accurate than angiography. So as we can't make out distal runoff, so this is one reason why most of the operators say we can't replace first injection with IVUS, when this was my beginning when I started this process. But slowly over a period of time, so I decided to replace my first injection also IVUS. If you have an angiography, you don't need any first injection to plan, how to use your IVUS. Otherwise, you may need first injection to plan your IVUS. So, but now almost I stopped even first injections in angioplasty, which I will show in this case. So this case directly, I started with RCA angioplasty. So we cannulated RCA, wide RCA. Then I did IVUS. This is the first IVUS through RCA. So with which we can identify, you can see this is the distal reference area, and which you can see in fluoroscopy. This is a point. So this is my distal landing point. So if you see a distal landing point, my block area is 43%. See, obviously block area should be less than 40% where your stent ends. So, and the reference lumen diameters were like 2.8 and 3.1 because and EEM diameters are 3.9 and 4.1. Because this patient has a diffuse disease, always you have to see the reference diameter after pre-dilatation. Sometimes there can be an increase by quarter size after pre-dilatation. We also decided, the length of the lesion. So this is the length of the lesion. This is ostium, and this is my distal reference point. So you can see the length of lesion is almost around 65 to 68 millimeters. So that says, what size of stents you have to use. These are the various sections at various level. This is the distal reference, and this is in the lesion, middle of the lesion, and this is almost MLA like 2 mm square or 2.2 mm square, and yeah, and this is the ostium. So ostium is relatively free, so in this case we can end at ostium, or we can slightly project it into aorta and stunt it. So, and if you see the reference points at ostium, so luminal references diameters were almost 4.1 and nearly 3.5, 3.75 to 4, and EM is almost 4.25. So we decided the length of the stent, and we also decided the post-dilatation balloons with luminal sizes. So we pre-dilated, vessel with a 2.5 balloon, and after pre-dilatation you can see the distal reference size has been increased to 3.3 to 3.6. Before it was around 2.9 to 3.2. So almost there will be a quarter size up after pre-dilatation. So we decided to take a 3.5 stent, and the total length being around 68 millimeter. So we have only 38 millimeter stent as the longest stent. So 3.5 38, and proximally another 3.5 30 28. So that is the sizes and diameters of the stent, and the length is already we discussed. And coming to the further injection. So while doing angioplasty, we keep doing injections in between. So what are the various reasons why we give? So it's position of pre-dilatation balloon, or assessment of vessel after pre-dilatation, and recoil to understand whether the vessel recoiled after pre-dilatation, and to look for dissections, and sometimes resizing of the vessel after pre-dilatation, and reconfirmation of landing zones, so based on change in anatomy and distal runoff of the vessel. So, and stent deployment. So during stent deployment, that is position of stent as well as selection of diameter and length of stent. And after stent deployment, to know stent expansion and need of post dilatation, and edge dissections assessment, and distal runoff of the vessel. So these are the issues which we would like to assess with in between injections. But can we replace all these injections with IVUS? Yeah, positioning of pre-dilatation balloon. So of course we can replace, you mark your distal and proximal reference points in fluoroscopy, and based on those points, you can position your pre-dilatation balloon. And assessment of vessel after pre-dilatation or after rota, I think IVUS is the best tool than angiography to assess vessel block modification with block modification measures. So, and we can also decide, upgradation of birds, upgradation of your block modification strategy with IVUS better than angiography. Dissections, of course, IVUS is superior to angiography. Resizing of vessel for stent selection, of course, IVUS is superior. Confirmation of landing zones, IVUS is superior. The only thing where you can't assess with IVUS is distal runoff. So, and stent deployment, diameter and length reconfirmation, yes, you can do with IVUS. Positioning of stent is possible with IVUS by fluoro IVUS integration, or at least marking your distal and proximal landing zones with your fluoroscopy. But in osteal lesions, it is a bit difficult. You may have to give some injections to position. And post-deployment assessments, of course, IVUS scores over angiography in understanding stent expansion, apposition, and edge dissections, except distal runoff of the vessel. So the only thing which you cannot assess with IVUS is, which is a bit difficult, is positioning of stent, especially in osteal locations, and distal runoff of the vessel. These are the two things which you may not be able to understand with IVUS. So how to handle? See, positioning of devices, already I told you, you can, with co-registration of IVUS into fluoroscopy, it is very easy. If there is no co-registration, you can actually mark your distal reference in IVUS and proximal reference in IVUS with a fluoroscopy. You can mark it and you can do it. But in osteal lesions, another thing for IVUS positioning, if you can take a liberal sizing of the stent, that is length of the stent, probably see, you never miss lesion. So this is also helps. But in osteal lesions, invariably you will end up in giving some injections while positioning stent. Distal runoff, so you cannot assess with IVUS, but there are certain things which you can with which we can understand, like speckling. So if the speckling is increased, so that clearly says your distal flow is slow. So, but operator should be very cognizant of this speckling pattern in the first image and the image which he is doing. So with that you can understand. But otherwise this can be replaced by asking patient repeatedly for symptoms, that is in between your procedures. Ask for symptoms and have a look at ECG. Are there any changes in ECG? So if there is no symptoms and no ECG changes, don't worry about distal runoff. So only when distal runoff is good, patient never complains of symptoms and ECG never shows changes. So or sometimes as I told you, excessive speckling also increases suspicion of slow flow in IVUS. So with this we can replace all your injections, in between injections. So we pre-dilated, right, and then we took another balloon 2.7532, again pre-dilated entire lesion, and then did IVUS to understand any change in distal diameter, distal reference diameter. So as I told you already, it's changed by quarter size, so we took a 3.5. In post pre-dilatation, I understood the balloon was not completely dilated in some areas. That's why I took a Scoreflex balloon, and we went up to high pressures with Scoreflex balloon. So, and once the lesion is prepared, so stent selection is done. So now it's a positioning of the stent. So this is my distal reference point. So you can see it's almost 3.5. So, and this is the length of the stent. So my first stent is 3.538. You can see I'm just putting it at the point which where fluoro showed my distal reference point in IVUS. So I located exactly as per my IVUS distal reference, and then we deployed. So after deployment, so again, this is after deployment. After deployment, again I did an IVUS to understand the length of the proximal stent. You can see this is a distal stent from here to here. So you can see this is the overlap which I want to do, right? And this is the length of up to ostium. So from ostium to distal stent it is 23 millimeter, that is 24 millimeter. So I took a 28 millimeter because I have to overlap and put it into ostium. This is 3.5 28 millimeter. So we deployed. Yeah, I took one injection because it's an ostial positioning. So we gave 2 ml of contrast and positioned stent. So we deployed that stent and then took a 3.5 NC to dilate entire stent, and did an IVUS to understand the areas of stent under expansion. And because the proximal luminal reference was almost 4, so I took a 4 balloon to dilate the proximal RCA stent to up to 20 atmospheres. So that completes optimization and post balloon dilatation. And I'll come to the final injections now. So what is the role of final contrast injection? So the final injections, basically, you want to understand whether you have done anything to the cannulated site, like guide-induced dissections of proximal vessel, or any issues related to stent expansion and edge dissections and distal runoff, and wire-induced issues like perforation. So this is the goal of final injection. Can I replace final contrast injections with IVUS? Issues at cannulated site? Of course, yes. So, but all your final IVUS should come up to aorta. So whether it is left system or right system, your final IVUS should come up to aorta, so that you can rule out any guide-induced dissections. And stent expansion and apposition, of course, IVUS is superior to angiography. Edge dissections, again, IVUS is superior. Distal runoff, of course, you can't make out with IVUS, but you have alternative methods to assess, like symptoms and ECG changes and speckling in IVUS. So, and wire-induced issues like perforation, but this is one thing which you cannot really assess with IVUS. So these wire-induced perforations cannot be assessed by IVUS. So it may be safer to take one last injection before coming out of angioplasty. So in this case, so after post dilatations, so we did IVUS and we re-expanded under-expanded areas, and then I gave one injection. So this injection is basically to understand any distal wire-induced perforations. So otherwise, see, if you are sure about your wire position and wire movement, there is no need to give even a final injection. But in my practice, almost always I am giving only one injection, that is the final injection. So which may take 3 to 4 ml. So, and these are the areas in the stent. You can see this is the distal reference, almost 8.1. Yeah, this is a minimum stent area around 6.8 at this area, but here I dilated with 4 millimeter balloon up to 18 atmospheres. Still it was like that, but I avoided further dilatations because of eccentric expansion of the stent. In such a case, as you can see, the plaque is completely on this side and there is no plaque on this side. When you try to expand to more and more pressures, so sometimes you may create perforation, because stent tend to expand only to this direction. So never try to dilate. If the plaque is uniformly around the vessel, then you can go to higher pressures slowly and you can expand the stent. But when it is eccentric, so never try to over expand, you may end up in perforation. And at the ostium, yeah, we dilated with 4 and there is a good stent apposition, and overall it's okay. So, and yeah, this is a final IVUS and this is a final angiogram, you can see. So the final IVUS is showing uniform expansion of the stent all over. except in this area where the lumen size is around 6.8, okay, and but the block is quite eccentric, because of which I don't want to dilate further in that area. So this is about RCA, and then we went to LAD. So LAD, as you notice, there is a proximal lesion. So we I just replaced first injections with first IVUS. So I did IVUS and I marked this is my distal reference point. You can see this is the distal reference vessel, so which was around 2.4 dia, luminal dia, and the EM dia is around 2.75 to 3, and this is a proximal reference point in fluoro, and this is a proximal reference point in IVUS. So you can see the block area is less than 50%, and the lumen size is around 2.75 to 3, and this is the length of the stent which I am supposed to use, that is around 33 or 35. So I dilated with a 2.5 12 balloon, and then it is a 2.75 because the distal lumen was only around 2.6 to 2.7. I thought of taking 2.75, and proximally I would dilate with a 3 mm balloon. So after stent deployment, we dilated with 2.75 balloon, 3 balloon proximally, and you can see how it is optimized. So there is a uniform expansion of the stent. You can see the areas. The distal reference area was around 3.9 mm square, and if you see the stent areas all through, it is more than 3.9, so more than 100%. It's 4.1, 5.7 and 5.6. so we had a good expansion of the stent. So, and we took a last injection only to understand wire perforation. So we took only one final injection. So to conclude with the systematic analysis of IVUS, so we can replace most of contrast injections in PCI. In my practice, I replaced first injections and all subsequent injections, but I am still continuing to give one last injection to understand wire-induced perforations. Steps which cannot be assessed or replaced by IVUS or stent positioning in ostium. This is one thing which may need some contrast, and distal flow of the vessel, but this can be replaced, and wire-induced perforations. So this cannot be assessed with imaging. So the indirect markers of distal flow are, which replaces your angiography, are constant inquiry of patient symptoms in between steps and observation of ECG changes, which clearly tells about distal flow in the vessel. I replaced all the contrast injections except final angiography or ostial positioning. And IVUS co-registration will help us in positioning of devices, pre-dilatation balloons, and accurately. Thank you.